Hi, everybody. My name is Natalie Yeadon, and I'm one of the co-owners, CEOs for Impetus Digital. At Impetus Digital, we have built some of the best-in-class asynchronous and synchronous virtual collaboration tools that are used for all kinds of things like virtual advisory boards, investigator meetings, working groups, medical education. We do corporate events and on and on. But at Impetus, the most important thing here is that we really believe that all great ideas start with a conversation. And our online collaboration platform is the perfect place for not only starting these conversations, but also for continually building on these ideas and insights generated over time, and also creating authentic partnerships and relationships in the process. So having these big, hairy, audacious conversations is how we start to implement change and positively disrupt healthcare. So with all of that said, the idea behind this webinar series is that we want to start these conversations around some of these big or controversial ideas. We want to work with the provocateurs, the leading edge thinkers, the digital entrepreneurs, to discuss the opportunities and issues that surround us in the healthcare industry that we're facing today and find out how technology can help. So I'm really pleased to be having somebody that I'm super excited in meeting with, and that's Dr. Farah Furcond. And she is actually a medical doctor and a clinical researcher. She received her MD degree from the Herbert Wertheim College of Medicine at Florida International University in 2015. She is an NIH-trained, board-certified neurologist, neurocritical care fellow, and a neurointerventional surgery fellow specializing in stroke. So try saying that really quickly 3 times. She has worked at the front lines of the COVID-19 pandemic as an ICU doctor and is involved in clinical trials related to COVID-19 therapies. So Farah is also the author of a fantastic book, I can't wait to dig into this with her, called the Pandemic Manifesto. This is a COVID-19 educational resource for medical and non-medical people alike. Welcome, Dr. Farah Furcond. So happy to have you on the show.
Thank you for the wonderful welcome. I'm so excited.
That's awesome. So excited about your trajectory. A recent graduate, but again, a very, interesting background in being a neurologist. Tell us a little bit about your trajectory and how you landed in the place that you are, and whatever made you decide that you wanted to write a book.
Oh, well, I've loved the brain and I've been fascinated by the brain since I was a little girl. Initially, I knew I wanted to either do neurology or neurosurgery. I went to college. In med school, I was torn between neurology and neurosurgery, and I had mentors on both sides. I decided to go against the grain and apply to both specialties, which is something you don't typically do in med school, but I thought I want to give myself the best opportunity and go in whatever direction I feel is best. So then I found out about this unique physician scientist track at Georgetown, where I did half of my residency at Georgetown and then half of it at the National Institutes of Health, the NINDS, the Neurological Institute there. And I thought to myself, what a wonderful opportunity. My initial interests were in neuroplasticity, neuromodulation, and using those tools to enhance people with cognitive dysfunction, psychiatric disease. And I worked in a lab where we did neuromodulation with certain different sort of tools. I used transcranial magnetic stimulation, or TMS, and our group worked with stroke patients. And then I realized I love stroke. And then in my residency, separately at Georgetown, we did a lot of stroke. And then I realized I like using my hands. I wanted to do neurosurgery. So I thought a wonderful sort of continuum of that would be to do neurointerventional surgery. So then I was looking into fellowship programs, and typically after a neurology residency, to be a neurointerventional surgeon, you go through stroke fellowship and or neurocritical care fellowship and then neurointerventional surgery. And I found this unique program where it was all combined into one program, and I fell in love with it. And that's where I am today. So this fellowship is combined stroke, neurocritical care, and neurointerventional surgery in 4 years. And it sounds like a lot after residency. It's kind of like I think it's the longest fellowship ever. but it cuts off 1 year technically. It would be 5 if you did all of those separately. And then I get to be with this wonderful group of people for this whole time and learn the important things, meaning not have to move from place to place and go from place to place, but really find a group of people that I love to work with and are so passionate about neurocritical care, neurointervention, stroke, and are so passionate that such during the COVID pandemic sort of rose up and we all sort of rose up and went out of our comfort zone and went on the front lines because of our neurocritical care experience. We transitioned that into pulmonary critical care, medical critical care, infectious disease, and what have you. So that's where I
am. Wow, that is dizzying. Good for you. That is fantastic and so inspiring, Farah. So in amidst all of this, you found the time to write a book called The Pandemic Manifesto. Tell us a little bit about the inspiration about writing this book, how you found the time while you were working as a frontline hero in the healthcare world, and who are you hoping to target this to?
Okay, so this was my first book. I've published papers, that's part of being in academic medicine, but definitely my first book. I've always loved to write, but did so, when I was a little kid. So my inspiration, I didn't think I would write a book when I first started. We threw ourselves into it back in March 2020 at the sort of first wave in the New York, New Jersey area. And nobody knew what was going on. Even the younger doctors like myself to the older experienced doctors, everybody was on the same level. It was like just the great equalizer. And we went into it in the beginning, there was so much death, especially in the beginning, because the numbers were outrageous and nobody knew what was going on and patients were dying. And it became very difficult for doctors and nurses to deal with the fact that we couldn't do something. So what we did as a group is we got down, made a plan, tried to standardize the way we took care of these COVID patients. We targeted different organ systems that are affected by COVID and used our knowledge and extrapolated upon that, to use our common sense to build up something, because the evidence at that point was lacking. And even now, to an extent, it's a growing body of evidence that constantly changes. So I was working in the COVID ICU doing nights for a period of time. And I'm very good friends with the nurses, and we were just talking, and two of the nurses actually were wondering why we were giving melatonin to our patients. And these patients, if they had severe COVID-19, they were intubated, meaning they had the breathing tube down their throat connected to the ventilator, highly sedated. And melatonin is marketed as like a sleeping pill, even though it's not really a sleeping pill. So they were asking, like, why are we giving melatonin to our patients? These patients are very, very sedated. I don't think they need melatonin. And one of the nurses, she said, I asked one of the doctors earlier, but he said, just because. So the patients, sometimes the nurses were advocating for their patients and wanted to limit the amount of medicine they were just giving them. So given that this is sort of a supplement or vitamin, that's what it's marketed as, sometimes the patients weren't getting it. So I have a sort of side obsession with melatonin, and I love it. But I explained to them that it's not like for sleep. We're not giving melatonin for sleep. We're actually giving it because of all the antioxidant properties it has, anti-inflammatory properties it has, anti-infective properties it has that are, not well known. It's sort of a diamond in the rough. And yes, it may balance their circadian rhythm a little bit, but that is not the purpose. The purpose is to help with the anti-inflammatory, the cytokine storm inflammatory response that the patients with severe COVID-19 have. So then that night we were like, okay, we're going to make like a video series or something about COVID. So we made a list from A to Z of all, we found it to be the most simplest way, especially this was like at 3 or 4 in the morning. So, and patients were coding, and we were just trying to do this to keep ourselves going. So A was like azithromycin, and I went A to Z. Z was like presumably zinc. And then I started doing these little videos on my Instagram TV or Instagram Live, Instagram TV. And I would do them every so often. I tried my best to do them consistently. And then after a while, what I would do is I would prepare some at least bullet points so I don't forget important points of discussion. And those bullet points started adding up into pages and pages and pages and pages of material. And I just was like, I may want to collect these thoughts and put it into a book. And then one of the most memorable days, and truly the day where I thought this would be, that I wanted to do this, was April 17th, 2020. I remember, it's like the day I'll never forget. It was like the day that we extubated or removed the breathing tube from 5 people in our COVID ICU. Now, 5 may not seem like a lot, but at that time, like, patients were not coming off the ventilator. Patients would come in with COVID-19, go to the floor, be treated, go home, frequently, thankfully. But the patients that ended up getting really sick in the ICU, they did not. So that Monday, we made a plan to take care of our 20 plus COVID ICU patients, but we wanted to pick a handful that we thought we could get off the ventilator and tee them up to the max medically by Friday to extubate them. And the goal of that was manyfold. It was for the patients. But honestly, it was for the morale of the nurses, the doctors, the staff, people who were just like, once they get on the ventilator, it's all over. So we worked, and then Friday I went in like 6 a.m. and then there were about 7 patients or so who we had worked with during the week who we thought we can get these people off the ventilator. And this will be the first time that a patient who was actually really sick with COVID got off the ventilator. And there were 5 people who met the criteria and could safely be extubated. And we went from room to room, removing the breathing tube. And it was like a little miracle. And I remember I was crying, we were all emotional. And then people were looking through like the glass doors, like, what the heck is going on in there? Did that just happen? And then we went from one room to the next room, to the next room, to the next room, to the next, and extubated those patients. And it was one of the happiest days of my life. We got to call the families and tell them this, and they were shocked because, families couldn't see their loved ones, or still can't. So that was the day. And on a side, we started a COVID clinical trial because our neuroclinical trials were put on hold for COVID. So we did that. And I was also learning and learning, collecting all the evidence on COVID in general on all fronts, and trying to keep up to date. So I thought, okay, I've had to keep up to date with this evidence-based medicine that's coming out to help with our COVID clinical trial. And I had this like amazing personal experience that we all experienced that day. And, I realized that there is a lot of even doctors and nurses who are super knowledgeable. Those 2 nurses are like amazing nurses. The fact that there's so much misunderstanding about COVID-19, I thought, I may not know much, but I certainly threw myself into it. And I can put together something that's meaningful for the general educated citizen who wants to make sense of all of the misinformation, information overload, whatever you call it. There's just so much out there, and so much of it is just you to really understand and think for yourself. It is so important to have a base, fundamental foundation of understanding like that. That way you really can, you can critically appraise things when you understand how antibodies work, how the cytokine system works, because that's nothing new. This is not new to COVID. These things are well known and preceded COVID well before that. So having that is not only empowering, but it's empowering, it brings confidence, and also lets you make educated decisions about how to move forward. And I really wanted to give people that because I found it to be something I really found useful too.
So Farah, that is a fascinating story, and what an amazing experience. And for you to actually lock and load on that exact day, that exact hour, when that decision or any drop for you to contribute to the world in such a significant way. And I'm sure in the lives of those patients that you extubated as well. But I just kind of want to take a step-by-step approach. And a lot of this was discussed in your book, but really kind of starting off from the very basics, which is we were just getting into a place of discovery. And testing was just in its infancy at the time that you'd written this book. We're obviously in a very different place now with rapid testing and what have you. What have you learned, early on? What has transpired in terms of testing? What's the right test? There's lots of concerns about false negatives and, and all sorts of other things, when you should be using rapid testing versus the traditional testing. What can you share with everybody around testing?
Testing. So for tests, the most important thing is the sensitivity and specificity. You want to make sure, you want to minimize the number of false positives and false negatives. And tests have variable degrees of sensitivity and specificity. Now, during the first wave, we didn't even have testing. So we were sort of figuring things out as we go, and patients that sort of clinically presented a certain way, we were like, okay, they're COVID positive. And oftentimes a patient, because of some of the lower sensitivity of some of the testing, we would actually test patients 2-3 times to increase the yield or increase the sensitivity. And patients would be negative and then be positive and positive. We're like, okay, they're COVID positive. But what we learned is that with regards to the standard testing, the nasal swab testing or oral testing, and in the setting of the patients we used to take care of, sometimes through the tube that's down the throat, it's very dependent on who's doing it. Sometimes people don't get a good sample because it's kind of unpleasant to stick that large swab up your nose and almost like evoke a tear and cough. It's very unpleasant. So it's very user dependent. Most of the tests now are quite sensitive, meaning if you're positive, you're positive. Now we'll go into what it means to have, sort of the SARS-CoV-2 infection versus actually having the COVID-19 disease, because an infection and disease are two different things. They're like they're completely different. And it's so important to understand those concepts as well. So I would say the testing now is accurate, as long as the user who's administering it is doing so and in a way that you'll know if it's right. You'll know if it's right. But I have to say that, especially now that some of the newer strains of COVID-19, of SARS-CoV-2 are coming in, sometimes these targeted tests are they're very, very specific towards a particular pathogen or particular strain, but they may not be for another strain. So I think that's something to keep in mind now, because we have a lot of patients coming in now who test negative for COVID-19, but all of the different factors that we take into account clinically, they really are acting like it. They have lung pathology. They have strokes, meaning their blood is thicker. They have strokes, they have clots in their lungs, they have clots in their legs. They're young people who have really had no other risk factors known and then come in fulminantly sick. So a lot of times we sort of treat them as COVID and may even presume they're COVID even if they test negative. Now, one of the things that I found to be underutilized is really the fecal testing of SARS-CoV-2. So just to step back, as far as the way that the infection sort of happens. So there's spike protein and the angiotensin converting enzyme, or spike and ACE. Now, spike and ACE are, spike is on the coronavirus. It's what makes it, gives it all those pointy little little tentacles. And the ACE is it within us. Now, ACE is everywhere in our body, a lot of cases in the lungs, but it's also in the GI tract. So there's times where people actually are test positive longer in the fecal testing, more so than the swab testing. So it's all about what their main symptoms are. If somebody is asymptomatic, let's say, asymptomatic has no COVID-19 symptoms, they may test negative or positive via their swab. However, they may still be carriers to some extent, because PCR testing is very, very good, but there needs to be at least some threshold of the virus amount in the blood or in the in wherever you're testing to be able to have a positive test. Now, as far as patients having sort of the respiratory symptoms are more likely to test positive, I think it's really, really important to highlight the different body systems that are affected by COVID, because I think that also has an effect on whether or not they test positive via the nasal swab. So, I mean, COVID-19, I think that the pulmonary issues are very, very important. However, it's almost like a red herring, because what COVID-19 or what SARS-CoV-2 is for people who get COVID-19 disease, it's a diffuse systemic process that increases inflammation in the body through this whole cytokine storm, which has become like popular in the media to the cytokine storm. Cytokines are small microscopic inflammation cells in your body that are part of your immune system. So there's an overabundance of inflammation and toxins, and damage to some of the clotting factors in the blood. So people have a very, very, very high inflammation in their body, and their blood becomes thicker or thinner. It sort of becomes unpredictable. So that leads to, if you can imagine, a lot of inflammation and damage to the lungs causes the oxygen to go very low, and patients can have a lot of respiratory issues, profound like hypoxia, profound low levels of oxygen. But this inflammation affects everywhere: the heart, the kidneys, the gut, the skin, the brain. And people can have strokes and bleeding and clots in the lungs and clots in the legs, and renal failure, which we saw a lot of, kidney failure, heart failure, disruption in the GI tract. There's so much. And I feel like that's something that a lot of people don't understand, that when we say somebody is an asymptomatic COVID patient, but who came in at 40 years old with stroke and blood clots everywhere, I would say they're symptomatic. They're just not symptomatic in the way that we've come to know COVID-19.
Absolutely. So great explanation of a lot of things there, the cytokine storms, the impact on all kinds of different body organs, visibly and invisibly, which again gives us the attribution of being symptomatic or asymptomatic. It's just the definition of it. I'm also just curious about your perspectives, especially over the last months, on some of the genetic work that's been taking place. We've heard about some recent preliminary studies through 23andMe and others that are attributing certain ethnicities and groups that might be more prone versus not to COVID-19. We're seeing sort of other sorts of dimensions, even potentially around blood type. I was wondering if you can kind of speak to that a little bit. Is there truth to that? Is there more? And I think layered on that is the overall question: are we ready to start talking about population management? Do we have enough trends, creating trend lines and bucketing and segmenting patient types by characteristic, by, health factors, that we can start to do that in order for us to be able to unleash some of the issues around closing down the economy? So there's a lot there, but I'm wondering if you can disentangle that for us.
Okay, so I do agree that there are genetic differences, and then there's epigenetic differences. So we'll sort of separate those. So the genetic differences, I will talk about the blood types and also some immunoglobulin types that people have. We'll get into that. Sounds gooey, but it makes sense. And then the epidemiology, meaning certain populations that have a higher incidence and prevalence of certain chronic diseases that in and of themselves make them a higher risk for developing COVID-19. So with regards to blood type, there's type A, type B, type AB, and type O. Now, there's actually been studies with SARS, which is one of the viruses that preceded SARS-CoV-2 or COVID-19. So SARS and MERS, those are two coronaviruses that affect humans kind of more severely than the others, like the common cold. So there's been research on this for many years, and now there is studies looking at blood type in COVID-19 as well. So it seems that type O people have, this is the one good thing for them because they're the universal donors, but they can't accept anything. But in this case, it's a positive. They have an anti-A antibody in the plasma that seems to lessen their likelihood of getting COVID-19, SARS-CoV-2 or COVID-19 disease. Now, on the other end, type A, they don't have anti-A antibodies because they are type A. They have anti-B antibodies. So there's been studies showing that they're more susceptible to getting SARS-CoV-2 or coronaviruses in general, because most coronaviruses do work with the ACE receptor. So the type O, because of their anti-A antibody in the plasma, are less likely, they have less likelihood of attracting the ACE that is responsible or largely responsible as a gatekeeper for SARS-CoV-2. So, and then there's something else that's not actually discussed much, but it's the immunoglobulins. So those are the antibodies that we have, the IgG, IgM, IgA, and then there's E and a D, but we don't need to worry about that. So IG stands for immunoglobulin, another word for antibody. Now, we all have antibodies. IgM is the antibody that rises up right away and fights an infection very early on. IgG are the antibodies that take a while to develop, but stay with you. And then IgA is, so IgM and IgG are measured usually in the antibody testing. Sometimes they're not specified and they're not like separated, but they're measured. IgA is not. Now, IgA is a immunoglobulin or an antibody that's found in all the secretions. So in the nasal passages, in the oropharynx, in the GI tract, everywhere, your tears. But different people have different amounts of IgA. And there's actually like genetic diseases where people that have an IgA deficiency are very prone to all sorts of infections. But even people that are healthy have varying levels of IgA. So there is some evidence that people with high IgA levels are maybe less in the nasal passages or whatever passage are less likely to be able to contract certain viruses, including SARS-CoV-2. So I think the blood type and then the IgA are pretty, they scientifically make sense. And at least as far as the blood type goes, there has been evidence and has been sort of studies done way before COVID-19 with SARS and now in SARS-CoV-2 that show that there is like a sort of pathophysiology that makes sense, but clinically it makes sense as well. And then there are the populations that are more at risk. So the CDC has a list of risk factors that make one more likely to develop severe COVID-19. Obesity, sort of all of the risk factors that contribute to metabolic syndrome, diabetes, hypertension, hyperlipidemia, obesity, smoking, asthma, COPD. And these risk factors they're not specific to COVID-19. These kind of patients are the ones who come into the hospital for whatever reason much more often than people who are otherwise healthy. So these risk factors increase the risk of stroke, increase the risk of heart disease, increase the risk of kidney disease. So these people are already at a precipice, and having this infection just throws them off of there. And they're more likely to get a severe course of disease. Now, there are different populations that have a higher prevalence of smoking, of obesity. And I think targeting those populations makes sense. As far as education, health literacy education, because that's like the most important. Patients can come to the doctor or the hospital and you tell them talk to them. You really need to talk with them, educate them, empower them, give health literacy is everything, because that's what they take with them when they leave the doctor's office. But trying to provide that on a community level or community intervention level makes sense. And then not only health literacy, but making sure that there's resources for them to maintain social distancing and all of these factors that we implement. And we say, maintain social distancing, wash your hands, wear a mask, but we need to make sure that these certain populations actually, it's logistically possible for them to maintain some sort of distance. Do they have access to gloves and masks and all of this? Because what we say may not be practical for people, and we have to sort of understand that and provide those resources if we truly want to make a difference in that regard. And these people also need more access to vaccinations and sort of the secondary things that we're doing now.
Beautiful, that's fantastic. With all of that said, so there's markers, if you will, preliminarily, you're knowing your blood type or, knowing that you have certain factors or whatever, and there's probably potentially ways of bucketing and segmenting people or being predictive. And I'm just curious about, we're going to talk about masks in a minute, but I also want to talk about a lot of the news that went out very early on around other preventative measures to help you out a little bit. You've already mentioned things like melatonin, but we've also heard a lot about things like vitamin D and vitamin C and zinc. How
Yeah.
much truth lies in those as ways to remedy or prevent or reduce your risk of getting COVID-19?
Mhm. So I think that, you know, many of these supplements are beneficial, but all when used in the right way, like anything else. So with regards to melatonin, it's a it's a hormone made naturally in your brain, in your pineal gland in your brain, that helps balance your circadian rhythm, and also has clock genes and longevity pathways. That's my whole things. I like longevity and neuroplasticity, but it has anti-inflammatory, anti-infective properties, which at least on a reasonable dose at night is reasonable to take. I'm always one to say less is more. And I think we're the society, it's like more is better, more is better. It is not better. Not usually, not in medicine, it's not better. So going to the store and buying like the highest dose of melatonin and taking it at night is not going to prevent COVID-19. It's a good supplement to take with the idea that it has all these properties that could mitigate possibly an infection, but at a lower dose, because your brain naturally makes it. So when your brain or your body naturally makes something, you don't want to take too much of it because you impede your body's own ability to make it. It's by no means going to harm you, but as one gets older, or for somebody who is older, you don't want to reduce your body's ability to make something it makes itself. And that goes for many things. You could, the easiest way to think of it is people that take steroids for whatever reason for chronic disease, and then they become very dependent on it. And then when they stop it, their body's shut down. So this is not quite as dramatic, but you want to make sure that you take a small, reasonable dose a few hours before nighttime, and know that it's not going to put you to sleep. It's not a sleeping pill, but it may help you balance your rhythm out and has all these properties that could potentially mitigate an infection or an inflammatory process. Now, as far as vitamin D is concerned, so vitamin D is not just what we get from the sun, but vitamin D is an immunomodulator. It modulates or modifies or enhances the immune system. When I was in residency, we took care of a lot of multiple sclerosis patients, and one of the primary treatments we actually give them as an adjunct to their other medicines are vitamin D, because it helps modulate or balance the immune system. So that's the whole idea behind vitamin D in a disease like COVID-19 that wreaks havoc on the immune system and inflammation. Now, zinc is very, very, very cool. And actually hydroxychloroquine works with zinc, which I guess we could talk about later. But so zinc works on many, many fronts. It's also something that's an essential to our bodies and is used in thousands of different functions in our bodies, including DNA and RNA, which is like the mirror image of DNA, in all of those sort of in processes. So zinc has a very strong anti-infective characteristics, which is why zinc is in all of the like meds we take over the counter for common cold. So I think zinc, and there is lots of evidence on zinc as far as being having these strong anti-infective properties. So I think zinc, melatonin, vitamin D are very reasonable, but I also think they're not just for the prevention of COVID-19. There's something that are good. There are things that are good to integrate into our lives, or multivitamin, and it's not the cure. And I think that the tunnel vision of thinking, I want something to stop this right in its tracks, that doesn't exist. And it's more about understanding things on many fronts and stopping things or mitigating things on many fronts. So it's not a cure, but it
Absolutely.
is.
Yeah,
but good,
absolutely.
good to try.
Yeah, absolutely. I mean, why not? Now, I want to kind of talk about a couple of other things that bring up a lot of potential unrest for some people as we bring them into it.
Yeah.
And one of these has to do with other preventions. It has become a little bit politicized. It's incorporated with unfortunately, some negative propaganda, and that is about masks. And we've seen that this has actually been politicized. There has been various factions. So the mask has almost become a symbol of what political side you sit on, as opposed to doing what it is as it was deemed to do. So tell us a little bit about your interpretation. lots of new work coming up about mandating it or expecting it, and what was the previous administration in the US versus the primary, and now a whole discussion about double masking. So what's your thoughts on masks?
So I think people should just wear a mask. Now, I understand I have to wear like an N95, a mask over it, a face shield. I mean, it's a whole thing. So I think a simple surgical mask. Now, I understand how inconvenient it can be. I understand how, people make sort of comments on how it's inconsistent. People wear a mask, and sometimes, they're in a store and it says stay 6 feet apart, but people are all together, in line, but in the store they say 6 feet apart. It's like there's a lot of things that contradict themselves, and there are, because this is a growing dynamic thing, and everybody's trying to work with it at their own pace. And the whole world is working to get to from, the individual level to the government level. It's kind of just, it requires a bit of understanding, which I know we've all had to do. But so let's say there's an asymptomatic carrier and then a healthy contact, whatever that means, a healthy person who doesn't know they have any sort of risk factors. I'm not going to include anybody who's symptomatic, because I would, somebody who has symptomatic COVID would go be quarantine themselves or go to the hospital. So just the asymptomatic carrier and then the healthy contact. So if the asymptomatic carrier and the healthy contact are not wearing masks and they are within reasonable distance of each other, there's a good chance that the asymptomatic person could infect the healthy person, and then this person could get very sick, because healthy is it's a quotation sort of term. And then if the asymptomatic carrier is wearing a mask and the other person is not wearing a mask, there's a less of a likelihood of an exchange. And it goes vice versa, if the healthy contact is wearing a mask and then the asymptomatic carrier is not. And then of course, when both people are wearing masks, the likelihood of transmission is like 1%. But I think sometimes people, if they say, well, I'm a healthy person, I have no symptoms, I'm COVID negative, I don't want to wear a mask. Other people who are high risk, with all those risk factors we talked about, or are asymptomatic carriers, they wear a mask or they don't come here. Now, that's, if somebody can for sure say that they are 100% healthy, they have type O blood, they have IgA all up in their nostrils, they have no risk factors, okay, but I don't think anyone can truly say that. So it requires a bit of understanding, and to know that you're not immune, you're not excluded from what everybody else is trying to do. It's a sacrifice, but it's a necessary sacrifice, not just for other people, but for yourself as well, because you don't know how susceptible you would be. I have seen people who are 27, healthy, young men coming in with fulminant COVID-19 and getting intubated and dying, where they live at home with their grandmother who had COVID and is fine or ended up being okay. So these things are very, very unpredictable. And I think there needs to be a very little hubris or audacity there. You just to understand that when something is very unknown, every precaution should be taken for yourself, for others, and that's just the right thing to do.
So on that note, Farah, so, just moving along here is, obviously another big politicized, we've heard a lot about conspiracy theories. There's been a lot of political upheaval, as of very, very late, with all kinds of things battling around on that. And one of them has to do with anti-vaccinations and anti-vaxxers. Is COVID-19 actually happening or not? And you have people looking at the exact same thing and actually having a completely different interpretation of reality. Yes. So this also pertains to the vaccines that are available. We know the Moderna, the Pfizer, the Oxford AstraZeneca, the positioning and messaging of all of them, who should be getting what. So how do we sort of encapsulate this? Or what would you say to the anti-vaxxer around what's real and what's not? And how do you speak to people about interpreting things from a scientific perspective?
Yeah. So as far as anti-vaxxers go, and then on a separate note, people that think that this is not real, I kind of almost can understand where the anti-vaxxer, who was not previously an anti-vaxxer, comes from. I'll play devil's advocate. So vaccines take years, decades to develop. The Ebola outbreak back in the 1970s, there was not a vaccine until 2019, like 40 years later. And diseases like HIV and diseases that have so much funding and so much passion behind them, still there's no vaccine. So the fact that there's a vaccine within months is very alarming to people, and it raises like a red flag for a lot of people. And I do understand that. And myself, in looking at all of the different ways in which vaccines can potentially be developed, what happened is that the vaccine for COVID-19 was developed in a novel way. So that's what makes it different. So typically vaccines are live, sort of attenuated, or they're dead virus, or they're protein capsules. There's many different kinds. But there has not been a vaccine in humans that uses messenger RNA or mRNA. These are mRNA vaccines. Now, mRNA vaccines are easier to make and easier to sort of amplify or make a lot of product that can be available to a large group of people. Now, there are mRNA and DNA vaccines, and there is a DNA vaccine for horses separately for something else. But the concern with a DNA vaccine is that it could incorporate itself into one's own genetic code, which is very frightening for some people, which is frightening because then it would become part of you, and possibly to mutations and things that we can't predict, because the immediate effect of a vaccine is the same for every vaccine. You cough, fever, muscle aches, like a flu. But the real concerns are the long-term adverse events, like genetic issues or mutations. What's reassuring is that messenger RNA is different from DNA. That is made outside of the nucleus, or the little powerhouse or center core of the cells. So there's less of a likelihood of that happening. It's still a theoretical possibility, but it's less likely. So I think that can give one peace of mind, knowing that RNA sounds scary. It's your DNA. It could be incorporated into your bloodstream and lead to genetic issues down the road. But the RNA is separate, and that's much less likely to happen. Now, these different vaccines are using that sort of platform with mRNA, and that explains why things were so able to be so done so quickly. Now, there's hundreds of COVID vaccines on paper. There's many clinical trials still ongoing in different phases. But I am reassured. I was skeptical as to the speed at which this could happen, and if the trials would make it to phase 3 trials, which is the level of trial that is needed for the FDA to approve something, and that's because it's tested in many people. And that is also important, to test it in a large group of people so that you can catch a wide net and find any sort of patterns that would raise an alarm as to, is this safe to give to the general public? So I would say that for people at high risk, frontline workers, people with risk, I think getting vaccinated is important. And I think if the opportunity is given to you, that you should proceed with it. I think that the fear of it being harmful because it was made so quickly can sort of be squashed by the method in which it was made, because this is a method that hasn't been used in other vaccines. And the fact that it was tested in thousands, tens of thousands of people, and with multiple pharmaceutical companies doing this, it's not just one that's taking that's sort of taking over and has an ulterior motive. It's many different pharmaceutical companies that are working towards this goal with medical doctors and scientists to help give this. And I think that the whole anti-vaxxer movement should be put into a place where they understand.
I totally agree, Farah. A lot of it has to do with education, but at the end of the day, people will still have their own version of reality, as we've seen in some of the political upheaval that's happened recently. I just want to also touch on since you are a neurologist and very interested in neuroplasticity and cognitive behavioral science and all of that good stuff, there's been no doubt that after this COVID-19 and still continuing, there's been a huge impact on people's sense of wellness and mental health. I have actually seen for myself, very surprisingly, on regular cable TV, that there's all kinds of commercials that are focusing on suicide prevention. I've never seen that before.
No.
So what is your thoughts on the longer term repercussions? We hear about the long haulers, which obviously has their own specific health issues, but what is going to be the long-term impact on people's sense of well-being?
Wow. So I can speak personally for the frontline workers and for people in the general public, because I interact with patients who come to the clinic and they kind of almost vent to me about all that's going on, and and they're very open and honest. And then I think the long haulers are another group that really need attention. So with regards to frontline workers, I personally have tried to remain vigilant and positive. And when the second wave was coming and we all knew it was coming, I tried to remain positive, but this has obviously affected me very personally. And what would really has saddened me is seeing a lot of nurses and doctors almost have like PTSD from this, and really, really, really have that. A lot of nurses quit nursing. Some doctors decided to retire early. They just thought, I cannot do this again. I don't want to do this. And a lot of it is the disconnect between what we're doing here on the front lines and what people are doing in the public. And I think a lot of the frontline workers we're just flabbergasted at the anti-vaxxers, anti-mask. Is this real? Is COVID-19 something real? Is it a conspiracy? Is it fake? I think having to give ourselves so much and put ourselves out there so much, and then having that sort of rebuttal is very hard to swallow, very hard to go through. I think that there's actually been a lot more cohesiveness. Instead of keeping things bottled up, I've noticed that as part of the healing process is a lot of the frontline workers just talk about how stressed out they are, vent and talk and and that's between everybody, from the lady in the cafeteria to myself, to the transporter, to the nurses. It's just become a level playing field where everybody respects one another. Everybody appreciates what the other does. And that's how we've sort of healed or grown from this and are getting through this still. Now, for the people out in the public, it is very difficult. It's so hard for them to have to make so much sacrifices, not seeing their loved ones on the holidays, not being able to live their lives. And they don't have the opportunity, thankfully, to see what we see. So it's the complete opposite for them. They have to change their lives for something that for them is only real on the television or only real by word of mouth. And the only time they get to experience that realness if by some unfortunate chance themselves or their loved ones get sick. So it's like having to change your life and being told what to do without actually having experienced it is very hard. And the really unfortunate patients or the long haulers who had COVID-19 were either very sick or relatively sick and were treated and then given this clean bill of health and then go out and go back into the community, but they still have tons of symptoms that are non-specific and hard to address, and they go from doctor to doctor trying to get some answers and often are very dissatisfied or dismissed, and that is really frustrating. One thing that I've seen the long haulers do to get through this is actually make groups, like on Facebook groups and different groups, to discuss their challenges. And I really think that's been very helpful as far as getting them through this, because a lot of them feel dismissed by physicians, but I think that that's not intentional. Doctors have a hard time admitting they're wrong and have a hard time admitting they don't know stuff. If they would work with their patients, say, you're having all these symptoms, honestly, I just don't know. Not dismissing, but acknowledging that we barely know what we're doing now. It would be so hard to learn what the sequelae of this is. That's going to be something we have a firmer hand on years from now. And I think having that transparency would actually be empowering for these people. So I mean, they're just handling it on their own terms, really, the long haulers, and making their own groups and finding each other and trying to do their own research, get their own evidence together. And for long haulers specifically, I think that my book and whatever are the resources they would be able to find can help them like get to the bottom of things and figure out what's wrong, what's going on with their bodies, you know? So
Absolutely.
it's difficult for everybody.
Yeah, it is. It's a very, somebody actually said this very eloquently to me the other day, and they said, we're trying to fly the plane while we're building it. And I think that is so true in this particular situation. It's so impactful.
Yes.
So I really wanted to sort of tie this up by asking you, obviously, there has been a groundswell of momentous change and acceleration. Everything from technology adoption to a complete change in the service industry. You know, the economy has had a bit of an economic, you know, K economy recovery, where the poor are getting poorer and the rich are getting richer. We're seeing all of these kinds of bizarre, interesting, never before unprecedented behaviors and events happening. So as we potentially prepare for what some people are calling is going to be, you know, episode 3, you know, pandemic version number 3, or the next upcoming pandemic that will inevitably unfold. What are some of the key lessons learned here? Everything from supply chain to preparation to regionalization versus reliance on globalization. What other sort of big factors have you ascertained are the key learnings for us moving forward?
I would say there's a couple. I would say one is that no one lives in a glass house or a plastic bubble. No one is immune from anything. I think a lot of the unfortunate events were lack of preparation, and not lack of preparation because there's not resources, lack of preparation because you don't think this can happen to you. So as we saw things going from China to Italy to other countries, instead of mobilizing here, we sort of just thought this is not going to happen here, and then it did. So I think there was an opportune time to really get things in order, to prepare the public, to not just to prepare them for all of the changes they would need to make. Not just it's here now, just do it, just wear a mask, just stay home, you're not going to work. Like, it just came on so hard, and people generally were just blindsided by it. I think if we would have been more mindful that, okay, this is becoming not just, you know, isolated to one country, but slowly going in all other countries, we would have started like educating the public, saying this will come here. These are things we should plan to do. Give people a chance to acclimate, to adapt, instead of expecting them to just evolve in a day and change in a day, because that is one of the hardest things to do.
Yeah.
So
absolutely.
I think that, like, not thinking that we're not excluded. You know, we are definitely vulnerable, if not more vulnerable. And then after that, once the pandemic has spread to the United States and it's here and it's everywhere, it's even learning from the initial first wave in New York and New Jersey, rather than, and we saw this, rather than other states. So we went from national, this can't happen to us, to other states going, this can't happen to us. Other states, my home state, Florida, I'm from Miami, people were going out to the beach, people were going out to the nightclubs, doing whatever. When I was here, you know, watching people die in the ICU, and there's our hospitals overloaded with COVID patients, we're on a lockdown, we're not doing anything. And we see other states thinking, let's just continue as is. And when it gets here, we'll act upon it. And then after our wave sort of ended or was coming to its climax and was going down, other states had their sort of effect. Now, the downstream effect of this is that lack of preparedness elsewhere means when we eventually have our peak again, then we don't have the resources we used to. We had military nurses and traveling nurses and all these traveling doctors coming and volunteering their time to come to New York, New Jersey during our first wave because it was isolated to us. And then now it's spread, and then all of our resources are stretched thin. Yeah. So I think it's more like this process of like preparation, giving people and institutions time to adapt and evolve rather than just bam, bam, bam.
And I think it actually speaks really nicely, to be honest with you, you being a neurologist and knowing and understanding neuroplasticity. I'm sure you've read a book by James Clear called Atomic Habits. At the end of the day, everything is habitual behavior.
Yes,
Doing
yes,
things
yes.
repeated over and over, 1% at a time, until it becomes a new acclimatized behavior. And I think that's really a key lesson. I think at the top of the hour, I just wanted to say we could honestly talk for days about this. And I'm hoping that we can probably have a conversation again when this is all over. But for those of you who are listening or watching this great interview, we do want to let you know that we will be posting this soon with a link. And in our show notes on our YouTube and podcasts, and actually in the web and our website, we will be leaving the links for Dr. Farah Fourcand in case you want to connect, ask more questions. We highly recommend as well reading her book, The Pandemic Manifesto, certainly full of all kinds of nuggets, and only we scratch the surface of all of the pearls of wisdom that are in that book. I also invite you to check out our website at impetusdigital.com. If you are remotely interested in some of these really hairy, audacious, provocative discussions, these kinds of things that go beyond the pill, we're talking about policy changes, working with patients, decentralized trials. How do we do this? How do we do that? Working with allied healthcare providers, payers, patients in these digestible touch points using Impetus's virtual collaboration tools that we help you to manage. So you're developing and building these relationships over time. So check us out at impetusdigital.com. We also encourage you to like this video and subscribe so that you can hear new episodes and so others can find this as well. So thanks everybody for your time today. Thank you as well, Dr. Fourcand. This was an absolutely amazing conversation, and we're wishing everybody a great day ahead.